when we see a patient, I'm not going to do what a manufacturer tells me to do on a treatment table. I'm not, or other disciplines. I'm going to follow, first and foremost, the innate instructions from that patient. I'm going to look and observe that patient. I'm going to see the posture of the patient. Basis for all of these slides basically show that different positions do different things to your spine. The eccentric elite, or your adjusting techniques, should take that into account, whether it's on a flexion distraction table, whether it's in the side posture position. Knowing that you have literature supporting and studies supporting what positions do to the spine, if you take that into account when you adjust, or you use the eccentric elite, which is multi-positional, three-dimensional, your results can be better, can be improved. Basically, all of these studies discuss flexion, improving the diameter of the spinal canal, the dorsal sac, opening it, extension, closing it, unless you're talking to Harrison of the biophysics technique group, where everything is extension, and Cox is arguing with them, everything is flexion. You have to follow innate to know what to use, regardless of what the literature indicates. Here we can see the sagittal diameter, the cross-sectional area smaller with facet stenosis. As the facets approximate the canal, the ligamentum flavum is pushed in, the non-compressible fluid dorsal posterior fat pad is pushed up, the cross-sectional area gets less. This is a normal spine. This is a degenerative spine, so the lateral recess, number 8, is smaller. This patient has lost a certain reserve space. You combine that with the extension, and you're really closing down on the area where the nerve, the dural sleeve exit the spine through the lateral recesses and the pedicles. Provocative testing the patient. That's part of your key analysis when you're dealing with patients and what position to put them in. So these manufacturers and apostles of a specific technique that doesn't take into account innate wisdom. For instance, if the patient is bent for right lateral flexion when he comes in, I'll be damned if I'm going to put that patient and do some axial treatment. I want to make sure that the patient comes in like this way, is not forced into position this way. Now we know flexion opens up the canal space. The literature tells me it does. I got a bigger dorsal sac. There's more room for a compromised nerve root. However, forget about that. Throw it away, this study. Because I don't follow innate. The guy's like this, and I put him this way, and I begin to axial decompress him. Stretch him. We know stretching helps. Right lateral flexion, right lateral leg pain. That would be a medial disc herniation, right? It doesn't mean anything medial, lateral. What it means to me is when I go like this, it increases his pain. So initially during his treatment, I'm going to start his treatment out mimicking his bad posture. Work of traction, whether it's following a logarithmic curve or a straight linear pull or a ramp cycle that we have on our unit, it's irrelevant. Traction produces changes in the spine. What happens if those 32 patients that didn't respond to conservative care were put in the position of flexion first, to challenge it to see whether there was relief from pain? That number would go up from 35 patients to probably well over 60 patients of a cure if they followed the patient in pain-relieving position. So if Mark has relief this way, you can challenge the patient right lateral flexion. Does that increase your pain? In a medial herniation, you're actually creating a little bit more room for the space between the disc and the nerve root, and now he has relief. What you're going to do now is you're going to challenge him the other way. Does that relieve or aggravate your pain? In medial disc, It'll aggravate this pain. Does it hurt when you go backwards? Yes. Does it relieve you in this position going backwards? Yes. Where does it increase the peripheralization of the pain? Down the leg. That's primarily important. Does this send you more pain down your leg? Yes. Does this give you less pain down your leg? Yes. So in this particular patient, you may want to use extension, decompression. Now, we just demonstrated that extension was an important position to be in, right lateral flexion. So we're going to turn you around. And everything is options on this, is optional what you do. It's total flexibility in treatment of care. You've got to do your provocative testing. Just throw away that paper of what this says. If it's not practical and a practical application to the patient during your provocative testing, your observation, then don't do it. However, there are cases when you do provocative testing and there's no positive sign. The person has pain down their leg and there's no position makes it worse or makes it any bit less. So what do? Well, you can refer to your literature, your studies. Chances are, if it's a patient over 50, he has some stenosis. Based on the work of O'Neill, the lateral recess gets smaller as the facet joints come in, crowd the lateral recess, combine that with a disc bulge. Now with the extend track, we can affect soft tissue structures, we can separate the joints, we can have some effect on the structure that's going to open up a little bit. That's what flexion distraction does. You can do flexion distraction here. It's power mediated. It combines distraction with axial decompression, which was at first just gravity-based. Gravity works. Some patients you can't put into a power stretching mode. You can't say, okay, get on my table, lay in an axial position, and let's just start stretching it. There's gravitational, gentle, natural body weight. I know that's very critical to stage your treatments. You don't want to be aggressive. Believe me, this table can be aggressive. It goes up to 200 pounds of effective distractive force. So he's delivering multi-directional, fixed position, distractive changing. Now Oleg, who was face down on this unit, dorsiflexural weakness, didn't get results from a strictly linear pull, which is multi-directional disc decompression. He got results, the combination of multi-directional disc dynamics, which is a word we coined, for doing a actual pull under mobilization or range of motion. His vertebrae and disc immediately made an audible release. His leg strength was restored. One of the biggest features of this table is you have both. We're able to do gravitational, power-assisted. Gravitational, you're actually driving the leg system outward with the pelvic belt attached and changing the rotational angle of the patient. So you have the ability to get both angles. You can roll this table downward. But what's fabulous about this is the ability to be hands on the joints move. You want to qualify and quantify how much tension is on the ligaments. And we're able to touch the spine, so we're moving the joint right where we are. Whether he's conus supine, I'm on the spine. There's nothing between me and the patient. And I'm able to find out and exactly what. I feel my skin is spread. I can put as much as 200 pounds on him if I want to, of distractive force. So I'm able to challenge him when I want to go to L4. I'm a little higher and I'll feel L4 begin to move. Then I'll distract the position. And of course the mobilization is key. Circumduction and movement. A full range of motion.